I'm nervous because we didn't go over the question.
Okay.
Hi, everyone. Welcome to the second live session of Body 101X.
And what we're going to do today is we're going to have you guys ask some questions. You've already submitted some questions. There might be a couple from the first part that we carried over. Not sure. I sort of glanced through them, but I don't know what's going to be asked. So Andras and Jasmine are going to alternate asking questions. If there's anything for a physical exam, Andras will be our standardized patient, as we say when we do exams. So what's the first question?
There you go. Are humans really designed to go barefoot? Would Dr. Schreier recommend, say, going shoeless in a 30-minute Zumba session?
There's been a lot of controversy over whether we should run barefoot or run in shoes. And the research is tough. It's just tough to do because different people will respond differently. And in this type of intervention, no shoes and shoes, there's just a lot of factors that would make us think some people are going to get better when they run without shoes and some people are going to get worse when they run without shoes. So if you've always worn shoes, first of all, the theory is that you have nerves on the soles of your feet, and that provides information about the ground and stimulation to your feet. And so your muscles will be a little bit more tense. And when they're a little bit more tense, not too tense, but a little, they can help support the arch of the foot. And then that translates up to your shin and your knee and your hip and your back. And that seems to work for some people when they start to run barefoot. They do change their gait. But if you're used to a particular gait for years and you suddenly change it, your body isn't adapted or may not be adapted for those changes. And so you get a sudden increase in load in certain parts of your body, in certain parts of your feet, which translates again up to your shin, your hip, and your knee. And so you might end up with pain. The other part is that if you're not used to being barefoot, your feet will generally be very soft. So if you're in a Zumba class and the floor is okay, that might be okay. You won't have the problem. But if you're running outside on the grass or the road, you're likely to get cut up. And if you have any decreased sensation, some people with diabetes have decreased sensation in their feet, that could be much worse. So it's not a one answer fits all. Luckily, if you do it once or twice, there's not you're not going to die from it. And so what you can do is try it barefoot, try it with shoes, try it barefoot, try it with shoes. See what feels better to you. And if you feel worse, don't do it. If there's no difference, then it might be more long-term and you might be better with or without. So that's a way of copping out, but I think I did it pretty good.
All right, next question. The student is asking about patellofemoral pain syndrome, and they're saying that they have strong quads already and that they just don't stretch enough. Can you talk about this? Should they continue strengthening their quads, which is what her brother told her to do?
Okay, I need the model. Here we go. So this is the model of the knee. I think we used this last time too. So this is the model of the knee. And I don't know if you can see, this is the patella, and it's clear here because it's cartilage, a lot of cartilage, but it's a bone too. And this is your thigh bone, which we call the femur. And so patellofemoral syndrome is how your kneecap, patella, goes up and down in that groove on the femur. We're not very creative. Just use Latin words. So the problem is that if you sit, I'll do this with my knee, okay? If you sit and just relax your knee, oh God, now I gotta relax my knee. Okay, there. See how much my kneecap moves? So you can imagine if my kneecap was moving like that when I'm running or walking, my knee's gonna get really sore. That's not what happens. Now, if I contract my quads, my kneecap doesn't move. So the quadriceps muscle tracks the kneecap up and down in that groove properly. Now the question was about vastus lateralis, which is the outside muscle. If that's strong, that's not the problem. It's not a weak vastus lateralis, it's the weak muscles on the inside. Because the kneecap is, because of the way we're aligned, is naturally pulled toward the outside, and we want to hold it towards the inside. So it's the vastus medialis that has to be strong. You can imagine, let's say it is really strong, but it's slow to contract. So first this muscle contracts, it's going to pull it to the outside, and then vastus medialis pull it to the inside. And again, the kneecap's walking all over there. So it's going to get irritated. So it's not just about strength. It's also about the muscle coordination and getting everything to work together. A lot of therapists really focus on stretching a lot, because the theory is if my quadriceps here is tight, then when I bend my knee, I'm going to be driving that patella into the kneecap. But we don't usually do much activity with our knees fully bent. So when I'm jogging, my knee actually doesn't bend that much. So flexibility for the quadriceps might be important sometimes. The other is that there's another piece of tissue that comes from the outside, not the vastus lateralis, that's a muscle, but the tibial band, and they have fibers that sort of come into the knee, and what happens into the patella, and what happens there is it can pull the patella off to the outside a bit if it's tight. So we try and stretch that out. And then there's also, as we move up, if your hip is tight, that might affect your gait, which causes stress on your knee, to the angles to change on your knee. And so you might want to stretch further up. And so this is where the art of medicine is that a syndrome, this is called patellofemoral syndrome, is when you have a constellation of symptoms and signs. So I have pain, I have swelling, those types of things, that come from a bunch of different causes. So one cause might be vastus medialis weakening. One might be that it's not firing at the right time. One might be that my hip isn't working properly. And those are all different causes of this syndrome. And the art of medicine and therapy is to try and figure out which treatment is most likely to work. So we try a treatment, maybe do a couple things in combination, and then if that's not working, we switch and we change. The worst thing you can do is just continue down a path that's not helping you. So 3 to 4 weeks, you should notice significant improvement no matter what you're doing. And if you're not, then you should, whoever is treating you should take another look and a close look and try and figure out maybe there's missing something. Next.
When you get a sports-related injury, the student gave an example of Theodor's knee and do strengthening exercises. How do you know if the knee is getting stronger? So how can you tell if the uncomfortable feeling of doing the exercise is building up the muscles or actually aggravating the pain of the joint?
So there's a couple of things. One, the question was Theodor's knee. I'm not sure what you're referring to, but we do have something, patellofemoral syndrome that we just talked about with the kneecap, has something called Theodor's sign. For people who are rich, and movie sign for those of us who aren't. So, and basically what that is if you sit for a long time, as if you're in the theater or a movie, depending on what you like to go and see, your knee feels stiff and it might start cracking, and you feel like you have to crack out your knee, and then you get moving and it feels better. So that's the first part of the question. And then now I lost my train of thought.
The second part is how do you know, or how can you tell when the uncomfortable feeling from doing the exercise is building up muscles or aggravating the joint?
So when we do the exercises, there are different philosophies and for different problems. I think we talked about it in the tendinitis part in the lessons. In general, for my philosophy, I don't want my exercises to be hurting the patient during, after, or the next day. If they're not hurting during, after, or the next day, then they're good because they're keeping you mobile and active and increasing strength and proprioception. The problem is sometimes our nerves get confused because what might normally feel as fatigue might be misinterpreted as pain after an injury. So what I tell my patients as a rule of thumb is that if it's a little bit sore during the exercise, but as soon as you stop, it goes away, then that's probably okay. And if over the days, the exercises are getting easier, then that's again a really good sign that it's okay. But if the exercises are getting more difficult and more painful, then either the exercises are being done incorrectly or they're not the right exercise. They're too intense, whatever that is. And that really should be reevaluated and maybe stop. Or maybe you're making yourself worse because you're doing something outside the exercises. You decide that you're doing the exercises and you also decided to go hiking every second day and you don't normally do that, which might have nothing to do with the exercises. So you use that feedback. Now, if you have no pain during the exercise, but the pain comes on an hour later and it's throbbing for an hour or two, that is probably not good. And what I suggest to the patient is that they back off. But if they want to push it, then do that for a few days. And as long as that throbbing that they get an hour later starts to come on later, so instead of an hour later, it comes on 2 hours later. Instead of lasting for 2 hours, it's only lasting for 30 minutes. So it's that progression in time that is the most important sign whether or not what you're doing is good or bad.
Okay. The next question is chondromalacia patella is fairly common in adults who are physically active and is sometimes likely to result in osteoarthritis. Once cartilage degeneration has begun in this condition, are there any indications on what physical activities or practices can prevent the damage from increasing?
So chondromalacia means softening of the cartilage. Normally when we talk about the knee as a diagnosis, it's chondromalacia patella. Did he say chondromalacia? Yes. Which is patellofemoral syndrome by another name. So one of the causes of patellofemoral syndrome is softening of the articular cartilage on the bone. So if you remember, we talked about anatomy. We have the bone, and you can maybe see that this is rough here. And then here you've got this blue stuff over the shiny. And if you eat chicken, you break the knee from the thigh, you'll see a really white, shiny stuff. That's articular cartilage. That's what we're talking about in chondromalacia. Chondromalacia patella is the articular cartilage over the patella. And then the meniscus is meniscal cartilage. So we have different types of cartilage. Once the cartilage is softening, what we know, if you remember the osteoarthritis lecture, is that in dogs that are running moderate, 4 to 5, moderate speed, that the cartilage actually thickens. Now we're learning more about cartilage and how it can be regenerated. We used to think that once it got thin, it was thin and that was it. It's still true that once we don't know of ways to really thicken it and bring it back to normal, but it does seem that exercise and being mobile is healthy for the cartilage and helps maintain its thickness if it doesn't increase it. Some people argue that certain medications, glycosamine and chondroitin sulfate, can help. Not really been shown. They seem to help in the pain, maybe reduce the thinning of the cartilage, but reversing, I don't think I've seen that. So the key is also that even if your cartilage is thinning, a lot of people have moderate to severe arthritis with no pain. And we know if you have moderate to severe arthritis with no pain and you're active, even running, you're not more likely to worsen your osteoarthritis or need any total hips at all. So I wouldn't focus on the cartilage thinning and the chondromalacia. I'd focus on the symptoms, and I'd focus on making sure that you're in shape and that the activity you do matches the fitness that you're in. And we can define fitness by both muscle and cartilage, but really if you're not having pain, you're not having symptoms, for me, it's okay. There are a lot of doctors and orthopedic surgeons, sport medicine doctors, who would say that's not true. But we did the lesson, and I would suggest that you look up those papers that are in the references. Lane and Stanford did those series of studies, and look at them and then discuss them with your doctor, see what they think. If you've got your meniscal cartilage removed, that may be a different story, because there you've already changed the biomechanics and it might be too late. We'll have to see. Not all the preliminary research was it's too late, but there are some weaknesses in it. We'll have to see how follow-up studies work.
Could you comment on how diet plays a role in exercise and sports for athletic performance, recovery, endurance, overall health? Basically, how important is what you eat?
No, I'm not a nutritionist. We can certainly say that there are a lot of controversies, and there's some very well-respected people, scientists, who have taken positions that are outside the box, let's say. And I haven't had and Tim Noakes is the person I'm talking about. And Tim is a brilliant guy, and I haven't had a chance to sit down with him and talk to him. I know him over the years. And what I've learned is, although on the surface, I don't understand why he's saying what he's saying, I've learned that in the past, when I've not understood what he's saying, and then I sat down to talk to him, I've learned a great deal. So I don't think he's right in this one, but I'm not sure he's not right. Some other people are sure he's not right. Certainly, there is something about fat and protein. You have to have enough protein, and if you're breaking down your muscles, you've got to eat more protein just to replenish it, because you don't store protein the way we store fat. But all of those things are in standard textbooks, and I don't think there's anything outside that you can't see from reading standard textbooks. The rest of it, what I like to say is, people sometimes violently agree with each other. They're really on the margins. If you ask them, like, why is this right? Well, yes, that's going to work in 70%. This is going to work in 65%. And at that point, most things will work for most people if you eat a balanced diet. And if you're doing more endurance exercise and you're breaking down more muscle, you got to increase your protein. But if you're not, you still got to be careful about having too much protein. Again, too much of anything is bad. And too much protein, you can overload your kidneys, especially if you have weak kidneys. So you always want to be careful. And I would go with the general guidelines. If you're in elite performance, there are some special things you could do, but that's not what this course is about. This course is about general exercise. And so if you're at the level where you're trying to really compete and win a gold medal, then you really need to be followed and closely monitored. And that's beyond, way beyond what I know. Sorry. I hope that helps for the rest of you, though.
So one of the students was asking about the ethics of research. So can you comment on how animals are still used for research purposes and what current testing ethics are? Do we still research, like those mentioned in the lectures, so dogs running on treadmills until exhaustion, or removing the meniscus of sheep to test for osteoarthritis later?
So I did my PhD in basic science, and it was animal research. But it's been a long time since I did that. I'm also separate from everything else, but a little personal. I'm actually vegan now for the last 3 years. So the idea of the animal research is a lot more bothersome to me now than it was when I was doing it. I don't think I could actually do it now, personally. I don't know what the level is in research and where we are and what's being done and not, because I'm not following all the basic science research. We do have, all of the research goes through ethics committees. And the ethics committees are made up of people. And some of those people come from the community. I believe in the system. And I believe if we want to change the system and you feel that the ethics are not right, that we can have an effect. It just takes a lot of energy. And if over the whole population, there is more energy to learn more about osteoarthritis through research in animals, then there is energy in the population to stop learning about osteoarthritis by doing research in animals. I just think that democracy should win. And I'm willing to accept that not everybody's going to believe like me. Certainly, sometimes the sheep suffer. If we don't do that research, then what can we learn from it in humans? And so those are difficult questions. that there are no correct answers. And that's why we have bioethics committees with the public on. And I encourage you to get involved in your local area and maybe try and expand if this is something that has real meaning for you.
All right. You mentioned that pace can affect the relationship of the benefit versus risk on health for runners. What could be the pace above which running becomes less beneficial? The same question regarding distance. Are there any studies mentioning a distance level above which the benefits gained on health are decreasing?
You know what? I don't remember talking about pace being bad for. Oh, it was a study. That was it. It was one of the studies who was looking at correlations and what predicted problems. And it wasn't that you were, maybe there was some number, but that would have just kind of been a little artificial because it's based on that one sample. And so I don't want you to think about fixed numbers. The real important point is the principle in that was that if you thought it was impact that was the problem, then it is not pace that determines impact. It is every time you step. And in fact, the faster you run, there's actually less impact because because of the way they're running. So the point of that was not whether that pace made it worse. It was just to argue that this idea that impact wears out your joints, you just shouldn't think about that. And so the pace, one of the issues there, I don't remember if I got into it, is that we look at a lot of different variables. And if we pick 20 different variables, then something's going to look like it's important, even though it's not. It was just by chance. And if we redo the experiment, we're going to find something else out. There was a brilliant article on chocolate and how chocolate helps you lose weight. I'm going to try and find the reference. I guess we probably didn't have this, but we could have done it in the research part. How chocolate helps you lose weight. And they did a randomized trial, and chocolate did, and the media picked up on this, and it went all over the media. And then the authors came out and said, we fooled you. And how did they fool them? And it's all written up, though, like the study, the original study in the web, and then how they fooled. What they did was they had measured like 20 different things. Like they gave chocolate and they measured weight loss, they measured energy, they measured sleep, 20 different things. Out of those 20, weight loss, in this particular sample, there was more weight loss in the chocolate group. But if they had found sleep, because maybe it would, if they redo the experiment, chocolate's not going to have an effect on, it's not going to be on weight loss, it'll be on sleep. Or it'll be on, I don't know, taste or smell or whatever it is that they measure. So we have to be very careful. We call that reporting bias, where researchers who have their own, we had talk about conflict of interest, researchers have their own conflict of interest because they want to show what they want to show because it's their career, will often only report 2 or 3 outcomes that they measured, but they measured 20, and they won't even tell you about the others. And sometimes it's like chocolate. And so this is something that we're fighting some of us in the research world are trying to get other researchers to be more honest. And one way is to make data open. And I personally strongly believe this, that if you're doing a study and you go through the whole thing and the researcher has your data, that data is not owned by the researcher who can decide, well, I'm going to report this, I'm going to report that they should make all of that data public. Keeping you anonymized, of course, because you want to be, but keeping you anonymized. And then what would happen is if all that data is open, this person who looked at chocolate, I could go look at the study and I'd see that there were 20 different outcomes that were actually measured. And I'm going, well, what about the other ones? And then we would know that almost immediately. Now, there's been a lot of movement in the last few years. My own perspective, nobody's listened to me when I keep mentioning this, but I haven't gone out and really pushed it, is that if I'm going to enter a study, I'm going to insist that my data is made public. Now, if we all did that, and the researcher said, well, no, we can't do that, then they won't have any research. So us, as the participants in the research, as patients and just participants in any research, if we say to the investigators, we all will only do this if you make it public, they will have to solve all the problems that exist about making it public. Right now, everybody comes up with the problems or challenges, and there's no incentive to find solutions because the solutions will cost money and time and effort. If we say we're not going to participate, now they have motivation. Try and figure out their motivation. So maybe one of you has the energy in your area to try and push this. I'd love to see it happen because the open data solves a lot of problems.
In lesson 2, video number 4, you mentioned stretching your triceps will strengthen them, but at the same time, the antagonistic muscle, the biceps, will get weaker. So what do we gain from stretching our triceps if this is going to weaken our biceps at the same time? So how much time do we need to strengthen our muscles without losing or mitigating those losses?
The example I was trying to explain with my biceps and triceps was to mimic what was done in the animals in which they casted somebody. So when you cast somebody in this position, the triceps is being lengthened, and if you cast them for the week, it'll actually be stronger at the end of the week, but the biceps will be weaker. But if you're just stretching and then moving, you're not going to get weaker because you stretched your triceps and your biceps is contracted for 20 seconds a day. That's not going to happen. Don't worry about that. So if you're stretching, but you stretch that 20 seconds, that does provide enough stimulus in order to get the stretch-induced hypertrophy. So regular stretching is good. Both you'll feel less pain because it gets rid of these aches and pains, changes your pain perception. You do get a little bit stronger. You can move better, more flexible if you're trying to bend over and tie your shoes and you can't get down to tie your shoes, and now you can get down to tie your shoes, you're going to be more functional. So the stretching long-term regularly is good, and I just don't worry about the fact that your muscle's short for 20 seconds. Not a problem.
A student is an avid runner and considers himself fit, but suffers from calf pain after running long distances. So much so that he can't train for a week or so after running these long distances. Is this normal fatigue that requires rest, or is it an injury that needs treatment? So basically, what are your comments on calf fatigue and calf injuries?
After you exercise, having a little bit of soreness after might be okay, but really when you're exercising, you shouldn't be sore after. You might be tired. And sometimes we get confused between tired and sore, but that's lasting a couple of hours. When you do unaccustomed exercise, however, so I'm running regularly 10K and I suddenly bench press, for instance, using muscles completely differently than I used to do before, my chest will become really sore. We call that delayed onset muscle soreness. And if it's severe, so first of all, during the exercise, I won't feel much pain or any pain. But then 24 to 36 hours later, I start to get pain, which peaks at 2 to 3 days and can last a week. That's delayed onset muscle soreness. And this is what that sounds. And I answered it because that was in the discussion forum. I answered a question like that. So I think that's what this is. It's certainly, you can't tell until you really get together and look. There are certain other problems that can occur if you have muscle tightness and soreness after activity, even if it's not if it's not a lot of activity, and the amount of time it takes for you to become sore is getting less and less and less. Those are other conditions and injuries that really have to be examined. And in the calf, I mean, it can be shin splints, it can be compartment syndrome. We talked about compartment syndrome and stress fracture. It can be those things. So it really depends on exactly where the pain is and what's being felt. And we just can't do that on the MOOC. But it's not normal to have pain for 7 days after you exercise. So you're training wrong, or you have an injury, or both.
So sports like gymnastics and circus arts are constantly requiring the body to not only activate and perform, but to be pushed further and further for aesthetic reasons. So how do you best manage in training strength and flexibility? And furthermore, the student states that they perform multiple, high flexibility movements, and how to best warm up for these.
Let's deal with the warm-up first. Warm-up is really important for performance and for injury prevention. And it's not the temperature per se that's important. We say warm-up because when you exercise and you're contracting, your body gets warm. And that helps a bit. But it's really about your muscles synthesizing the enzymes and getting the machinery together so that you can use oxygen, and when your muscles contract, there's calcium being released and uptake and released and uptake, and we got to get enzymes to do that. So when your muscle is at rest, it doesn't have all these enzymes lying around. It degrades them because it doesn't need them. And then all of a sudden, then when you start to contract, it says, oh, I need more enzymes. And it synthesizes them on the spot, but that takes a couple of minutes. And then you're going to do more exercise. So then you need to synthesize more. And the higher the intensity or the longer the duration, the more of these enzymes you need, the more oxygen you're consuming, or the more force you're generating, the more enzymes you need. And so you have to give time, and that's what the warm-up is doing. It's contracting the muscles and allowing those enzymes and that machinery to rev up to the level that you're going to ask of it. So that's the warm-up part. If you're doing something like ballet, and you have to hold that aesthetic component, then you need probably to stretch before you exercise. That's not going to affect your injury rate positively. You might jump lower, but you're going to hold the aesthetic longer, and therefore that's better performance. So you have the stretching affects your performance in two opposite ways. One thing helps and one thing hurts. And then you have to judge overall whether that is an overall better performance for you than if you stretched or didn't stretch, or if you stretch for 30 seconds or 5 hours or whatever it is. And that's going to depend on who you are and what your general conditioning is. Did I get most of that?
Yep, I think so. But just as a follow-up question, in terms of them increasing their flexibility and going into further ranges of motions, is there any worries about joint instability, or like, are there risks at those really extreme levels of flexibility?
We talk about, or I talk about, and some other people, differences between flexibility and mobility. And flexibility is about your muscles. So if you remember in that time where I was showing the stretch, I couldn't, I was having trouble going out and touch my toes. And that was because my hamstrings were tight. There was no joint that was actually limited. But every joint has a capsule around it, sort of tissue that holds in the fluid, because the joint has fluid in it. If there was no envelope, then the fluid just escaped. And if that envelope is tight, that's mobility. And it's important that the joint is mobile. If your mobility is normal and your range of motion, you can get really high range of motion with normal mobility. There's no real danger there. The hypermobility is when you start to stretch out those capsules, and then that stops giving you a secondary restraint. And whether or not, and people talk about that being bad and as a risk factor, there are certain limitations to the research in terms of the inferences we can make from that. The muscles control the shock absorbent across the joint. My personal feeling is that if your muscles were working strong and well, you're probably okay. Things like contortionists, we don't have the answer about what happens long term. And yeah, they have a high risk of injury, but they're putting huge loads through their joints at the same time. So even if they weren't contortionists, they're standing on their hands, bringing their feet over. Yeah, they have problems in their shoulder and their back, but those are huge loads put through them. And maybe they would be having problems even if they put huge loads with normal range of motion. So biomechanically, you look at it and you go, wow, that should just be impossible. And if it's not impossible, it's got to be bad for you. It's got to cause injury. I just don't think we have the evidence. And so I think it'll cause injury. I'll be surprised if it doesn't, but I've been surprised before. So again, I'm not going to say that I know this. It's my inkling of it. And I really think we need to do more research on those types of sports. And it's tough to sort of get the same loads, but different range of motion. We're trying to do that in a study now with Cirque du Soleil artists, just to look at the different roles that people do and what their risk of injury is. But this is preliminary research, and we're just going to talk about these roles being associated with a higher risk or not. We have this theoretical picture, but we don't know if it's true. We'll look at the observed data. But, it's really limited because even if we we may very well show that people who do high loads and high range of motion have lower injury risks than those with low range of motion and low loads. Now, how could that be? Well, because they're different people. And what we've talked about here is that there are no contraindicated exercises, as my friend Scott Livingston says. There are only contraindicated people. And if you are in shape, if you train regularly so that you are always training at you gradually build up the load, gradually build up the range of motion, and that's the normal for you, then you're unlikely to get injured because your body's in shape for that activity. So I think we talked a little bit about it. I'm not sure, maybe we can check for Tim Gabbett's papers. We'll have to check and put them up on chronic load versus acute load, and showing that if what you've done in the last week is much greater than what you've done over the last 4 weeks, you're at high risk of injury. And so he's actually gone and shown that data in one data set. It'll have to be reproduced, but it's what we've said in this course and what we've been saying for the last 20 years. Start slow, progress gradually. What does that mean? Only increase 10 to 20%. What does that mean? That means in the last week, the amount of activity that you did should only be 10 to 20% higher than what you've done in the previous 4 weeks. So that's what Tim's done, and he just measured it. So we've been saying it for a long time. It's really nice to see that the research is coming out. His data on his set, which I think was done in rugby or Aussie rules, is a ratio of 1.5 to 2. So 10 to 20% is 1.1 to 1.2. So it's amazing that this rule of thumb that we've been using for so long and never actually studied is actually being supported. To go from 1.1 to 1.2 to 1.5, that's pretty cool. So we'll put up those references. I find that it's very exciting in terms of how we're progressing forward in return to play.
All right. A student, I'm assuming by their physician, has been told that that their left side has poor kinetic chain, and they would just like you to elaborate more on what that means exactly.
So the kinetic chain is that we think about when we throw a ball. If I throw a ball, I'm going to go boom. Where am I throwing that ball from? Where is that force coming from? So some people say, well, it's coming from your shoulder. But it's not just from the shoulder, because it's also the elbow has to go at the end. And that motion has to be fluid. If I throw my shoulder and then stop and throw my elbow, that's going to affect how far I can throw. And so it's this fluidity of motion about how the muscles are coordinated into this action. Now, in actual fact, most of the force when you're throwing doesn't come from your shoulder. It comes from your legs and your trunk. That when the pitcher, if you look at a pitcher or in cricket, that it is the wind up and the twisting of the body and the storage of energy. And so what you are taking is you're taking the energy from your legs and your trunk and you're twisting like that. And as you twist, you are converting that energy and moving it up the body. Kinetic means movement. So as these segments move one in sequence with the other, they're transferring the energy until it goes into the ball in a speed. Now, I used to have 2 dogs. And if my dogs, well, most dogs like to chase a ball, bring it back and run. My dogs like to chase a ball and then sit and then wait for me to go. And then they walk away. And then, so it was more like they do that 3 times and then they just stop going to the ball and let me walk around. So it was kind of like me getting my exercise. But if you throw a ball and you have a dog that really likes to run far, they have these plastic sticks. And at the end of the plastic stick is a little cup for the ball, and you just stick your tennis ball in, and then you just flick it. And that plastic, what it's doing is taking the energy from the flick and in a kinetic chain type way, transferring it all to the ball. As opposed to when I'm using my arm and my muscles aren't working in a coordinated fashion for the smooth motion, I end up losing a lot of that energy. So this way, with just a quick flick, I end up transferring all of the energy. And at least for me, the ball goes way further when I flick my wrist than when I throw it with my hand. So that's the kinetic chain.
Okay, the next question is, does scapular retraction prevent shoulder injury in overhead presses or similar exercises? And does it stabilize the head of the humerus in its socket?
Okay, so the second part, scapular retraction, has nothing to do with the humeral head and the glenoid. So if you remember, the humeral head is your arm, and the glenoid is that part of the scapula, your shoulder blade that it sits in. And I mean, that's held in place by muscles. So I think there's some miscommunication, but the scapular retraction means can I use you? Okay. So turn around here. So you're gonna have you take off your shirt? Okay. This is why I asked Andras instead of Jasmine. Okay. So this is Andras's shoulder blade here. I'm gonna outline it here. There. Okay. What retraction is retractor scapula? Okay. Is it moves towards the spine. And protraction is it moves towards the front of the body. So retraction backwards, forwards. Now, we give, in people who have rotator cuff problems, we often give exercises to strengthen the scapular retractors, the rhomboid muscles, for various reasons, but one of them is when the scapula protracts, we close the space, we narrow the space between the acromion and the humeral head. And just it's a biomechanical thing as it functions. So that's it. So sorry. So we often will give that and try and keep the shoulders back in order to improve the biomechanics of the shoulder. But retractors are not holding the humeral head in the glenoid. And I don't think a clinician would say that, but I could see where it could be misinterpreted because it is about exercises, scapulary retractors, to prevent the humeral head from riding up and pinching the rotator cuff tendons, but it's not this anatomical direct muscle link the way the question was phrased.
All right, next. What is your opinion on training while sick with cold or flu-type viruses? Should you ease off on your normal training, or is it possible to maintain normal habits?
Exercising while you're sick. Did we do a blog on that this year? No?
Might have been last year.
Might have been last year. Okay. if you have the cold, there's something called the neck check. And what that is if the symptoms are above the neck, then generally speaking, we believe there's no problem with exercising. Now, if you don't feel like exercising, you don't feel like exercising, but it's not going to be dangerous. If the symptoms are below the neck, so that you're getting a really bad cough and pneumonia, you may have pneumonia or bronchitis, that those things sometimes can be bad. If you have viruses in your blood or you get, you have any type of infection and you're exercising hard, we get worried because the increased blood flow can damage the valves in your heart, and there's certain bad things that can happen there. So as a general rule, this neck check thing above the neck is generally okay. If you feel like you're exercising, you feel bad, you just listen to your body. And if you're feeling okay and it's making you feel better physically, not mentally, but physically it's making you feel better, then that's probably okay. Just if you got high fevers, I think we don't know that it's dangerous again, but I would be careful about exercising with high fevers. You're just stuffed up. I wouldn't worry about it.
Right. So a student says they underwent surgery to have their meniscus removed, and a few years ago they discovered they have arthritis. So after being told not to run a certain distance, they decided to train for their first marathon. And after watching lesson 2 of topic 8, where you mention the focal increase of force in the bone, the student would like to know if it's wise to continue running.
So in lesson 8, I talked about the study on when they took out the menisci of sheep. And if it was me, I wouldn't train for a marathon. Of course, I'm not training for a marathon now. So you have to weigh the risks and benefits. The evidence suggests that at this point, I believe it would worsen arthritis because you don't have that cushioning. You're going to get focal increases of pressure on bone. And I just don't see the benefit of training for the marathon, but I'm not you. I'm not sure that I would stop running altogether. So I might be willing to take the risk. Remember, we had the return to play and whether you're accepting the risk or not. That's what we're talking about. It's just you're at high risk of osteoarthritis. If you run marathons, you're at much higher. I might continue to run 5K or 2K. Might still, because I really like going out if I go out for a 15, 20-minute run, I enjoy myself. Now, other people need to run 45 minutes to enjoy themselves. So it's all different. But I might say, you know what, for that, yeah, my risk of going osteoarthritis might go from 20%, because you got your meniscus out already, so you have a high risk. So maybe it's going from 20% to 25%. I'm going, you know what? I'm willing to take that risk. Now, I made up those numbers, right? The risk might be 50% to 60%. Like, I don't know what the risk is because even if I knew your whole case, I wouldn't know. We're making up those numbers. We don't have all the data. But that's what it's about, trying to assess how important the marathon running is to you, as opposed to marathon swimming or cross-country skiing or something else where you're not actually getting that type of focal increased impact that you would get with running. And maybe you might enjoy some other sport just as much as you enjoy running that gives you all of that thrill and adrenaline rush or whatever it is that you're getting.
Okay. I've always been able to crack my joints and have been told often to stop doing this because it will cause arthritis. I'd be interested to hear your thoughts on this. Does cracking your joints cause arthritis over time?
So I had a friend when I was in high school who used to crack his joints all the time, and I really thought he should stop it because it was really annoying. And he would just go lean his back and go crack, crack, crack all the way up his spine. We don't know that cracking your joints is bad. We don't actually know what causes it. There are a couple of different theories, and different professions have their own thing. Nitrogen bubbles, just soft tissue cracking. What does seem to be true from people that crack their joints, I can't actually crack my knuckles. I've always wanted to crack my knuckles, and I can't. I think I'm too scared to do it. I think I'm going to break my finger. So, is that people who crack their knuckles often feel that they have to crack their knuckles often. They feel stiff, and when they crack it, they get a sense of relief. And a few people I know who have stopped doing it regularly then feel that they no longer have to do it as regularly. So it's kind of a vicious cycle in both ways. The more you crack, the more you feel you have to crack. And if you can actually force yourself to stop doing it, you'll then stop feeling like you have to. And of course, doesn't mean you can't stretch, but you just don't do those high velocity cracks. In terms of osteoarthritis, as far as I know, there's never been a study. I don't know how we would study that. I guess we could try. There's always a way to do something, but I don't know of any studies that have ever looked at it.
The student asked, is there any difference between the use of NSAIDs for osteoporosis, for pain injury, and for pain relief and for injury? I believe there is no cure for osteoporosis other than a surgical intervention. So is there any reason for not reducing inflammation and pain with these drugs? I understand that there are undesirable side effects from overuse, but is there a better way to go in terms of relieving the pain?
I think the student is asking about osteoarthritis. Let's just talk about osteoporosis because that's what was written in the question. Osteoporosis is thinning of the bones. And we talked about that. Dr. Mountjoy talked about that when she was talking about the Rett syndrome. So osteoporosis doesn't cause any pain. There's no pain associated. And if you have pain, it's not due to the osteoporosis. What can cause pain in osteoporosis is if you fall down and you break a bone or you have stress fracture. Those cause pain. That's not the osteoporosis. If the student really meant osteoarthritis, then the NSAIDs are really working on a level of pain relief. And there are lots of different ways to have pain relief. Stretching, massage, acetaminophen, which is Tylenol, and Atazol here in North America goes by, can't remember the most common name in Europe. I don't know about Asia, but it's over-the-counter drug, and it has less side effects than the anti-inflammatories. The arthritis, itis means inflammation. We say osteoarthritis is really a misnomer. There is some inflammation, but it's not the hallmark of the problem. And in French, we call it l'ostéoarthrose, arthrosis, which means degeneration. And so the words have meaning. If you say arthritis, I need an anti-inflammatory because it's inflammation, and arthrosis, it's degeneration. Well, I don't need an anti-inflammatory, but it hurts me, so I'll use pain. So anything that you feel helps you for the pain can help. I still think that the strengthening helps absorb the shock, which decreases the stress across the joint, which decreases the reason for the pain, which is the best treatment. But you can use the things that I talked about, and ice and heat and those hot rubs, the things that have capsaicin in them. Tiger Balm is the Chinese one that people use. And those work simply by affecting pain fibers. And if that works for you, then that's okay. You're not treating the underlying mechanism, you're not treating the underlying stress, but you're relieving your symptoms. And sometimes that's really helpful, especially if you're in a lot of pain. Long term, for me, is the strengthening and the stretching when you're stiff, because you get the stiffness as well, and the proprioception, because you've been in pain and stiff that you're going to lose some of that. You haven't been as active, and we want to get that all back as fast as possible.
I've been told that active flexibility is better for injury prevention than passive flexibility. What is your opinion on this matter, and would you increase your active And how would you increase your active flexibility range of motion?
So active flexibility, for me, I don't like the term. Well, it's better than dynamic stretching. So dynamic stretching, did we went through this dynamic stretching? Dynamic stretching is where you can, it's not stretching, it's just contracting, putting your muscles through their normal range of motion while you're contracting. I told you warm up is important. That's what they're doing. They're warming up through the full range of motion. Absolutely great. Somebody wanted to make a lot of money, and so they called it dynamic stretching, and a brand new thing. If you're going beyond the range and really forcing with force like this, well, now you're contracting the muscle and stretching it hard. And as soon as you relax, at that point, the muscle is going to contract again. And when you go back with a lot of force, now what you're doing is actually putting force through the muscle while it's trying to lengthen it while it's contracting. And those are high loads. And I would argue you're prone to injury if you do those things. I don't know if that's what you mean by active flexibility. Other people think active flexibility is, oh, I want to stretch out my hamstring, so I am going to straighten my leg myself instead of just leaning forward. So, Frank, I'm going to sit up here. So active stretching might be if I'm here and I go like that and I feel my hamstring tightening. So that's active. I'm going to hold it and then I'm going to release. Okay, so that would be an active stretch. Whereas a passive stretch would be that I'm sitting here and leaning forward and my muscles just relaxed. There are ways to increase your range of motion. PNF stretching is one way, which uses these sort of active things. You contract the muscle, relax the muscle. You can certainly, in the acute phase, increase your range of motion dramatically with some active contraction and then relaxation. In the long term, I don't know any studies that show one is better than the other in terms of gaining range of motion in the very long term. If we want to learn from the experts, who we have to agree that the people who do the yoga masters are the experts, and they're generally passive, slow stretches that they hold for long periods of time. So I think that's generally safer. It's more relaxing. There is also a spiritual component to it, whereas if you're actively contracting, it's a different thing. But active stretching, where the first one I did where I'm contracting my hamstring, it's pretty popular now in therapy because it increases range of motion dramatically in the clinic. So patients like it. And if patients like it, they tend to come back to see the therapists. So patient satisfaction is high. I don't think it's bad, but it's got to be done properly.
Okay, so possibly the last question because we're running out of time. So in the United States, many children are labeled hyperactive and then given drugs to help them sit still in class. Can these children exercise instead of taking drugs? Like, can it be used as a treatment for this kind of condition?
So I'm not sure. I believe there is some studies showing that exercise regular exercise will improve these children. The attention deficit hyperactive disorder is a wide range. And we have to be careful about that. There are certain children who are really disabled by this problem. And they just can't focus in class. And if they can't focus, they can't learn. And so I don't want to say that you just stop the medication. I think that would be a mistake because it takes a while for the medication to work. And if the medication is working and you're wrong, the child's going to receive really a negative effect for a period of time. I would try stopping the medication in the summer when they're not in school so that you can then work out and you can try and test and you could have them read and see how they're doing. And kids sometimes do grow out of it. I mean, some kids grow out of it, not everybody. So you have to think about the pros and cons. I also personally believe that we're not made to sit around 8 hours. I mean, kids are made to go out and play, and our school system is not designed to allow that, and especially in certain environments, or that it's not safe, so they have recess, which is narrow, and there's no room to play, and it's all cement. They don't get to play on the grass. They don't get to run around. They're told they're not allowed to run because if they trip and fall, they're going to bang them. Somebody's worried about lawsuits. So we've actually curtailed their natural physical activity, and that will lead to some of the problems, I think, about the hyperactivity disorders. And so the more mild cases might absolutely be treated if we were out letting our kids be active as they wanted to be active. So I think exercise is important. I would encourage the kids to do it. And if they're feeling better, then then you might consider dropping dosage and things of that sort. But I wouldn't do this on your own, and I would do it in conjunction with your doctor and with close feedback with the teachers. You can't rely, especially in attention deficit hyperactive disorder, there's the deficit part where they're not paying attention. They don't know that they're missing things. And so you need the teacher involved to be, you can go to the teacher and say, listen, we're going to try decreasing the medication. If you notice a change, let us know so you can pick it up as quickly as possible and address any concerns that would happen. And the worst thing to do is just stop the medication and say, oh, what's going to happen over the next 2 months? Because then it's too late. Then the child's 2 months behind, they don't catch up, and they're going to have bad marks, which is going to may affect self-esteem and may affect their ability to progress to the next grade and a whole bunch of other cascading events. That's it. So we're an hour. I hope you enjoyed the course. We'll check and put up the references. Got to go back and listen to this and remember which references I said we would put up. Next, for those of you who are still doing the project, please submit your project reports. When you do, I keep saying it and I'll keep saying it, please let me use your report, even if it's anonymously, to let other people see the great ideas that you've had or the ideas that didn't work, so that they don't come up. They might think that it was a great idea and they'll see what happened to you and they'll realize, oh, that's not such a great idea. And they'll be able to do something else that is a great idea and that does work and be creative. We'll have next week, I'll do a wrap up. I'll be in Bristol, England, Bristol, UK, and I'll do a little screen thing myself. Maybe I'll try and get some guests to come in. I don't know if that's going to happen. Thank you so much for participating in the course. Really look forward to your feedback and the pre-post questions that you've done. Thank you for all participating. If you can, if you've done in the last one, we've tried something new on the post question for concussion. So I really encourage you to look at those, and if you can test them out, run them by. Thank you for the feedback, and hope that we see your friends next time on the next MOOC, that you spread the word next time we run this, and maybe you, if you want to see it again and participate in the discussion. And thank you again for all your questions. And of course, thanks to Jasmine and Andras and Frank behind the camera, and Claire and Alex and Adam and Laura and everybody else that has worked on the MOOC, that some of the people I know and some of the people I don't know, but I'm forgetting names. Thanks to everybody. And of course, thanks to all of you. It's really your participation that makes it.